general practitioner or family physician across the country are fighting for diabetes. And I'm sure we will not increase or we will not surpass the China. We still would like to remain number 2 in the world, but at the same time, we want to be a diabetes care capital of the world rather than diabetes capital of the world.
That is very nicely said. Rather than changing from diabetes capital to going to diabetes care capital, and that gives a really a brighter side of for our country. So, what do you think? What are the major factors which are contributing for increased prevalence in last couple of decades, which we have seen? There's an exponential rise in the cases of diabetes, which we have seen. So, what, according to you, what are the major factors for our country?
And Ketan bhai, not only for that, we are more worried because we are getting diabetes in a younger age population. So in compared to Caucasian, the other major problem is not that we are having higher number of patients with diabetes, but we are also getting the patients in their 30s, which was not there before 30 years. I mean, when your dad was practicing, I mean, uncle was practicing, he used to see the patient when they used to be in 50s or 60s or 70s. And now you and me started seeing the patient in their 30s, and probably the next generation. It's increasing the day by day in younger population. As I told you, the two major factor is, one is that the increasing active lifestyle, the physical activity is significantly decreased, and that I'm sure you will also agree. Rather, I will say that middle class Mumbaikars have a still good physical activity who goes to office in a local train because they don't get the seat and they have to remain all the time in a standing position, while those who are traveling in their personal scooter or two-wheelers or car, or the full time in out of 24 hours, how much time you remain in a physical activity, that's very important. The second important point is here is the diet. Now Indian is very peculiar. We have a diet which is higher in the carbohydrates. If you see the WHO, what they are recommending, one should not have whatever the number of calorie which he is taking, more than 50% one should not take from the carbs. 30% should be protein and 20% should not be more than that by fats. And what we are eating is 70 to 75%. There is a one paper where I was also the part, Shashank was the first author, which he has written that the starch study, even the patients who are going to a diabetologist or a physician, still after nutrition counseling, they are taking more than 65% of their diet which contains carbs. And again in carbs, what we are taking is simple carb. As you are Gujarati and what we are Rajasthan, Gujarat and Maharashtra, it is fulka, it is chawal. Even across the country, if you go in South India, they also eat the rice. Even if you go to the North India, it is paratha. So it is only the simple carbs which they eat. So not only the carbohydrate content of the diet is high, but it is the simple carbohydrate. And the last part is we are thin fat Indian. So even somebody who is lean, who looks very, overall his BMI is not more than 23 or 24, or may not be even overweight, but still he is typically a fat Indian, because there is a visceral obesity, there is a central obesity, and maybe one of the very important reason is we have very high number of persons having low birth weight. So, we are actually catching this adulthood disease in our utero. So it is a adult onset disease, but actually it starts as early as somebody is inside the womb, inside the mother's womb. So I mean, one comes early. It is low birth weight. Now we are seeing more of cesarean. We are seeing low birth weight child are more. The mothers are having PCOD. They have already pregnancy-induced hypertension. They have GDM. They come out with a low birth weight child, and this child who goes to the school or in early adulthood also, what he gets, every family member is trying to feed him more and more because this guy is very thin. And that's the reason, it is one of the important reasons that this central obesity is important reason for increasing insulin resistance. And once upon a time, once the person develops beta cell failure, he is going to develop type 2 diabetes, and there's an exponentially growth. And we started seeing in 30s, many of my patients, and I'm sure you also must be having in 32, 35, 38, 40. And above the age of 50, what we used to see before 20 years, when I was in my medical school, the diabetes used to be a disease of 50s. If we used to see a patient who is in 30 or 25, we have to think, is it type 1? So, I mean, a clear cut distinction was there. Now we are completely confused. A 18 or 17-year-old, yesterday only I had seen one young girl with type 2 diabetes. I mean, this is what completely paradigm is shifted.
Right. Now, you have very nicely said about the low birth weight. And as I remember, Professor Dr. C.S. Yadnik, who had done a large study about low birth weight babies and the outcomes. And this. In fact, I remember his words. Somebody had asked, that what can be the contributory factor and until what age is at risk. And he had clearly said that risk rise from womb to tomb. So till the
Exactly.
person dies, he is at risk and right from the womb. So you have nicely put. You have also opened a good Pandora's box, stating that as we are seeing more and more diabetic patients at younger population, we are also seeing the patients who are not obese or not even overweight and also having diabetes. So now, can you guide us or tell our delegates who will be interested in seeing that is there any factors at which they will have to start looking out beyond type 2 diabetes, because they may see somebody who is 28 or 30 years. So is it only on the age criteria, will it be on the weight or BMI criteria, or will it be family history, where when they see somebody who is diabetic they need to look beyond type 2? So can you throw some light on
So,
that?
I mean, you are now the diabetes is not like that, it's only a type 2 diabetes. Even you must have seen a new paper which is published from the Sweden group. And what they are saying, even a type 2 diabetes is also can be divided into different group. He had put a new classification, that is severe insulin resistance syndrome, SIRD. He had also classified some of them is a SID, which is severe insulin deficiency diabetes, SIDD. Then he
Yeah.
had put a mild obesity diabetes, which is MOD, and then he had put a MOAD, which is mild uh, obesity as well as age, which is responsible for his diabetes. So you are seeing some patients who are elderly or who are above the age of 50 or 60, and they develop diabetes because over a period of time, when the person is increasing in his age, and because there is a beta cell dysfunction, maybe genetic or maybe the reason is family history, he may develop diabetes. And many of these patients which we see in the age of 50 or 60 or 70, the others of them, some of them are because of they are overweight and obese, who are like 28 or 29 or 32 BMI, and they develop diabetes. And that type of diabetes, I'm sure you will agree that they can be reversed, because if we reduce their weight, if they go for bariatric surgery, if they go for GLP-1, if they come for the very low calorie diet, you can reverse them. Then you have a severe insulin resistance syndrome. So some of the patients who have a very significant acanthosis nigricans, they have the lean hands, and they are not, if you see the overall BMI, but they are primarily centrally obese only. And these are severely insulin resistant. And then we are seeing some of the patients not typical of type 1, but they are real lean, and they have actually insulin deficient diabetes also. One more which we are actually forgetting or missing or underdiagnosing is a condition called MODI, which is a monogenic diabetes. Uh, this monogenic diabetes of adults is actually a single gene defect, and they have a strong family history to their parents and grandparents, either of the side, maternal or paternal side. If three family member of that very strong family history, and they have diabetes origin, all these family history have the below the age of 30, and they are not typical of type 2, not typical of centrally obese, they are not typical of type 1 who is insulin deficient. I think we should suspect about the MODI. And now this genetic analysis can be done in our city, in our labs. It is not costing very high, but if patient is affording around 18,000 rupees, they charge for the genetic analysis of 18 different gene, which we can diagnose what particular type of genetic problem that person is having. And many of these patients, they respond to very well to the sulfonylurea. They don't need require so much metformin. They don't need DPP-4. So I will say it's like a precision medicine. You have to make for each and every patient a personalized medicine treatment. You cannot make a blanket therapy for everyone. Each and every patient is to be treated the way we should treat, like that. It is a tailor-made. It cannot be like a ready-made shirt for everyone. It has to be a tailor-made, perfect fitting for that particular person.
Correct. So, as you rightly said, that one shoe doesn't fit everyone. There will be a different sizes for different one. Now, courtesy all our societies, API, RSSDI, we have made so much awareness about the diabetes management and all. So now, when somebody suspects, all have gone. Even you must have seen HbA1c, which has now become a part of a routine investigative modality. So it was not just fasting and a post lunch, but people have started asking for HbA1c. So now, can you guide our delegates that will the first time newly detected diabetic, will it be on the basis of fasting post lunch value, or will it be on the basis of HbA1c? Would you decide whether this patient should go for a monotherapy versus combination therapy? So will it be on
Very
absolute
interesting, Ketan Bhai, you had
A1C?
asked, and I'm sure that most of the participant must be knowing, but still I want to again tell about that. That ED and WHO had clear-cut defined when you should diagnose diabetes. Like first time, when you are seeing somebody's fasting sugar coming more than 126 milligram. 126, why somebody will say cut off 126, which is equivalent to 7 millimole, and that is the cutoff value for diagnosing somebody as a diabetes. Now there is no like post lunch and post dinner. You have to do OGTT if you want to do the oral glucose tolerance test, and if it goes more than 200 milligram post oral glucose tolerance test, then also it is diagnosis of diabetes, which we normally we don't do it. If it is more than 126, we diagnose, and simultaneously we can use the A1C cutoff also. If it goes more than 6.5, it's definite diagnosis of diabetes. If it is between 5.8 to 6.5, below 6.5, we call it pre-diabetes. Or if it is below 5.8, that is 5.7 or 5.6, it is non-diabetic. That is A1C value cutoff. The post-lunch and post-dinner, suppose it is a random glucose we have to consider, and more than two times if it goes more than 200. If somebody have two value of random blood glucose, you have a patient who is sitting in front of you and you are doing a random blood glucose and it is showing 220, and one more report before 7 days or 10 days, either patient had randomly checked or he have a random blood glucose report of more than 200. So two reports of random blood glucose is also considered that person is having a diabetes. Suppose fasting glucose is more than 110 but less than 126, we can go for OGTT if we don't want to go for A1C. But nowadays, we don't give the patient 75 gram glucose. Rather than we get the HbA1c, but then it is known as impaired fasting hyperglycemia. So you have more than 110, but still it is the person may have HbA1c, which could be normal or which could be high, or it could be in a pre-diabetic range. But these are the patient called impaired fasting hyperglycemia. Now, what to start with these patients? At present, all across the world, all major guidelines, including RSSD and API, is also talking about the first choice of therapy is a metformin, as it is one of the best insulin sensitizer. But when to add or when to start with a two drug or when to start with a three drug? At present, there is no recommendation to start with three drug, but two drug to be started when HbA1c is more than 8.5. I mean, you have a target which is ideally to be 6.5 and it is more than 2. So, I mean, one can't expect that one molecule will able to reduce the glucose level by 2. But we had seen in clinical practice that some of the patients who are very motivated and they can reduce their glucose level or HbA1c even more than 1.5 or 2 by metformin also. So it depends again patient to patient. The second choice of the drug which we add on after more than 8.5 or 9, then we start these patients on 2. Again, it depends whether you want to add the first as a DPP4 or multiple cardiovascular risk factor. You can straightway start with Sglt2 or metformin. Triple drug, at present, no guideline is saying that start with that, but it can be always added. But if patient initiate and come with a insulin deficiency type of complaint, I mean, he's having polyuria, polyphasia, weight loss, all those things, or HbA1c come first time more than 10, then what we can do, glucotoxicity is to be reduced fast, and we add and we should start these patients on insulin therapy along with metformin if it is a type 2, and then slowly the insulin can be removed from the therapy, because these are the patients who have very high glucose level initially, and then their sugar level can be controlled by adding the insulin with these patients. So I mean, this is what the international guideline, this is the national guideline, and what you and me are following in our clinical practice. And I'm sure most of even family physician and primary care physician, if they are treating and they have interest in diabetes practice, they must be following the same.
Right. So very nicely you have said that, higher A1C or a very grossly symptomatic patients, where to reduce the glucotoxicity, you will give them the insulin, and then rest depending on the levels, start with mono or combination therapy. Now here, one point which came into the light and suddenly changed after 2.5 decades was the first time when EASD came out with their position statement stating that up till now we were considering metformin as a first line, and for the first time last year they came out with a recommendation: if the patient has got underlying ASCVD or a heart failure, even SGLT2 inhibitor can surpass metformin and can be used as a first line therapy. What are your viewpoints on that?
So Ketan
Because
bhai,
that, yeah,
I
after two and a
fully
half decades.
yes, sorry. I fully agree with you. So, what was the guideline? The ADA, ESD, and AS guideline also from 2018, because in 2015, the EMPA-REG outcome trial had come in September. And then it was realized that these are the molecules which are reducing not only atherosclerotic cardiovascular disease, cardiovascular death, and particularly hospitalization for heart failure. And then we have a now trial with the DAPA heart failure, and even Emperor also come before 2 days. So we know that these are the molecules which reduces significantly hospitalization for heart failure, and significant MACE reduction is there. So what they are saying, that after the first choice of metformin, if you have a patient with an established cardiovascular disease or no established cardiovascular disease, they should be treated in a two different way. With the patient with established cardiovascular disease, if patient is primary with heart failure and kidney failure, think of SGLT2 as a choice of therapy if eGFR is more than 45. If you have a patient where atherosclerotic is to be reduced, it has to be GLP-1 analog. Now, European Society of Cardiology was, what they had said, suppose a cardiologist is seeing a first time a patient with a heart failure or a established cardiovascular disease. And you know that you and me also see many patients in ICU. And when you are just getting, patient is getting hospitalized, and the first time we see patient with CVD along with the diabetes had come. Now, it is a confusion whether we should start these patients on metformin or SGLT2. Now, why they recommended, this patient might be having a HbA1c of 7 or 7.5 or even 8. What will you add? If this patient is more than 8.5, definitely you will add metformin and SGLT2, because two drugs are to be recommended. But this patient is not having HbA1c high. So instead of metformin, I should give the SGLT2 inhibitor to this patient to reduce the cardiovascular event in future. And if I will give him only metformin, or I will add metformin SGLT2, the patient may stop after some time SGLT2, considering that metformin is an anti-diabetic drug and patient will be otherwise well controlled with metformin. Why he should take SGLT2? So the primary idea of here giving is SGLT2 is prevent the cardiovascular and to prevent hospitalization for heart failure. And that's the reason they surpass that. We should not use here in this case as a metformin as a first choice. Add first choice as a SGLT2 if it is a drug naive. If it is not drug naive, then at least metformin and SGLT2. Suppose this patient is already on metformin and DPP4, and you are seeing a patient in ICU. Even his sugar is well controlled. He is having HbA1c of 6.5. Now, what should be the treatment? Should I continue the same? No. You stop DPP4 and put the patient on metformin and SGLT2 and discharge the patient in that. So the complete idea is that SGLT2 should be on board. It is in a molecule of a choice with a patient who are having established cardiovascular disease, or patient with a reduced heart ejection fraction, or patient with reduced eGFR. but it is more than 45.
Right. So very important message for our delegates that like how for post-acute MI, all patients are on beta blockers and statins. Similarly, for a patient with ASCVD, we must have, if he is a diabetic, on the board, SGLT2 inhibitor should be there. So depending on the whatever the the sugar levels, you may give combination, but if it's a monotherapy, obviously SGLT2 will score over metformin in this class of patient. What sir has rightly said. So
Ketan bhai, but now recently after the DAPA heart failure and Emperor study, even non-diabetic patients, the significant decrease
yes.
in hospitalization for heart failure, and probably now all cardiologists will be also writing all their patients with reduced ejection fraction, like they are
Absolutely.
writing the sacubitril, the same way they have to add the SGLT2, even the person may be a non-diabetic also.
Correct, correct. So that is going to go now also in the cardiology domain also.
Yes.
Okay, now coming to a very practical issue also, a diabetic who is following with family physician who has started him on a metformin, there are no other compelling comorbidities to add another drug. Over a period of time, he is not controlled on metformin. Say he has given up to 1.5 grams of metformin per day, not controlled, and he wants to add a second line drug. There are no other comorbidities or compelling indication for any other particular thing. What do you think? What should be the second line choice given a neutral scenario?
So
If
one
cost
very
is not a
Yes. So one, we should be very aggressive in an early course of the treatment. Most of the diabetologists and the diabetes care center, they are seeing the patients only late after 10 years of diabetes with some or other complication. So you have always an opportunity, those who are taking care of these patients at a primary care physician, to treat these patients in first 5 years and 10 years. And as you rightly said, Dr. Ketan Bhai, they don't have any compelling indication because patient is not having ASCVD. At that time, patient is not having CKD, no heart failure. So they can choose any of these molecules. But still, you will be surprised to know that, Ketan Bhai, there was a clinical inertia which was published in 2013 to 2015. It is a NHS data, National Health Service data, where all these patients are treated by a primary care physician in UK. I'm sure you must be knowing how UK is practiced. The endocrinologists are supposed to see only the patients who have complication, only type 1, all patients of more than 10 years of diabetes. Otherwise, all patients are to be treated by a primary care physician and they have to refer the patient. Still, the clinical inertia is so much so that after metformin, the second addition of the drug, which may be sulfonylurea, which could be DPP4, which could be alpha glucosidase inhibitor, which could be SGLT2, or which could be even the glitazone. But the addition of the second line itself delayed the therapy from 1.3 years to 5 years. Even the patients were supposed to take the medicine free. Doctor is supposed to give these patients medicine free and consulting free. All these patients were supposed to follow the doctor every 3 months to 6 months, depending on their whatever the follow-up duration which is written by the doctor. So my point is that we are not having so much aggressiveness in our therapy. Early and aggressive control will give them a lifelong, a legacy effect. And that legacy effect is very, very important. In UK PDS, they had shown that early and aggressive control of these patients will have lifelong, less complication, not only for microvascular complication, but for macrovascular complication also. So first and foremost, my request to all our participants that we should be early and aggressive. We start with the patient with metformin, but we forget the lifestyle modification is very, very important. These patients should be followed very regularly. The second choice of the therapy, when you don't have any compelling indication, it could be metformin plus glitazone, alpha glucosidase inhibitor. It could be metformin with DPP4 or SGLT2, any of these molecules, depending on the glycemic pattern of the patient. Like I have a patient with a fasting sugar had come to 95, but the postprandial sugar is 220 and patient HbA1c is 8.5. What would you like to add? We will talk to the patient about the nutrition counseling. We will say that this will not only increase your sugar level over a period of time, But diet control is very, very important. Carbs cut out down has to be done. And this time I am adding you alpha glucosidase inhibitor. You have a other patient where fasting is high and postprandial is not very high. Patient is doing good, but this patient I have to explain more about the exercise. It will improve the insulin sensitivity, and I will add this patient as a insulin sensitizer, maybe a glitazone, if there is no contraindication for that. The third variety of patient, which is very safe, which nowadays we are using because DPP4 are comparatively safe, less side effects, can be given even on a teleconsultation also. You need not to worry so much because less than 3% of the patient have some or other issue, but it is a weak anti-diabetic, we know that, and it can reduce HbA1c around 0.8. So I'm fasting and postprandial. If you have both the issues are high fasting and post meal both, and you want the weight reduction, I think the SGLT2 still even compelling indication is not there. And now in India we have the molecules which are cost effective SGLT2 which is available to us. We can give these patients even that SGLT2 also. Sulfonylurea, where will you place? Now that's an important question. I'm sure Ketan bhai, you must be asking me that the
Yes.
person whose sugar is more than 9 HbA1c, he is already on metformin. Now, if I want to add these patients, any drug if I add, it will not reduce the A1C of around 2 or 1.5 plus. So these are the patients who can be started with sulfonylurea. But when we are adding the sulfonylurea, mind well that this can go in hypoglycemia. We have to talk to the patient or educate the patient about the hypoglycemia part, self-monitoring of blood glucose. Sometimes we have to de-escalate the therapy after some time. Once glucotoxicity goes away, maybe you started a patient on a glycoside sustained release 60 milligram. After some time, it has to come 30 milligram. Similar way, glimepiride 2 milligram. Patient has to come back to 1 milligram also. And these patients, sometimes you add along with sulfonylurea one more drug. So it could be a triple drug therapy also. I'm sorry
Right.
for a long answer, but because
No,
it is like a complete guideline.
correct, absolutely. You are giving a beautiful idea to our delegates about guiding them further in the diabetes management. Now, coming to that, since you mentioned about sulfonylureas, we have glimepiride available, glyclazide, and of course the age-old glibenclamide, which is also available. You have or you prefer any one over the other when you have to select amongst SUs?
So I will not select the glibenclamide, even it is available to our country. One of them, it is yes, very strong anti-diabetic. Glipizide I may choose because it's a short acting. Even with the patient with a renal dysfunction, also I may use the glipizide, which had not shown increase in hospitalization for heart failure, while
Right.
Sexa and Elo had shown. We don't have the data for Vilda, teneligliptin, and we don't have the data as far as cardiovascular trial is concerned. But if you see the black box warning for even all gliptins, including even Sita and Lina, which had shown non increase in hospitalization for heart failure, but still US FDA had put a black box warning for all the patients who have heart failure. They should not be given gliptin as a drug because it increases hospitalization for heart failure. But suppose your patient who is not going to take GLP because of the either it is contraindicated, not affording, or not ready to take injectable, then out of these four different gliptins, at least you choose Sita or linagliptin. This is what is written in a guideline. They don't have evogliptin, they don't have vildagliptin, they don't have teneligliptin, and that is the reason they had not put. Now, the concern for teneligliptin is about the QTc interval prolongation. In clinical practice, we may not see the QTc prolongation, but definitely it is an increases the risk for cardiac arrhythmia, particularly a patient who is also a patient with a cardiovascular disease, who might be taking beta blocker, cordarone, some other molecule which can increase the QT interval. Even hypoglycemia itself also increases the QT interval. So if your patient is on sulfonylurea and insulin, that can also increase the hypoglycemia. And over and above, if the person is taking like hydroxychloroquine and all many more molecules which can increase the QTc. Now, many of my colleague may say that I had never seen a patient who is dying because of teneligliptin, or I had not seen a patient who is having QTc interval increase. You might not be seeing that patient because either this person might be dying because of a sudden cardiac death, which we may say that this might have died because of acute heart attack, because we don't do the postmortem. We don't know whether person is died because of myocardial infarction or arrhythmia, or person is hospitalized because of pro-arrhythmia or arrhythmia. So it is very, very difficult at this point of time. We don't have any data for Wilda, but there is uh, a phase 4 vivid trial was done where it had
Yeah.
shown that it is comparatively safe in compared to teneligliptin. Evogliptin, we don't have again the data for this point of time. It's a molecule which is available from the Korea, and this molecule is also long acting, does not require, I mean, the same way the teneligliptin. So I do use all gliptins, but if I have a patient with an established cardiovascular disease, I will prefer that person is going for the either Sita or linagliptin.
Okay, so I think we as Indians always get the opportunity to have a variety, a big basket to offer. We are always like a choice, and we are Indians have been always offered a variety of choices to pick up from, and that is why it creates more confusion and more dilemma also. But you made the points very clear. Now coming to same SGLT2 inhibitors, now you have a various glyphosines. So have you got any particular choice between the all the whether it is Cana or DAPA, or you have got the largest study which came with the EMPA, and now you have Indian glyphosine, so Remo, which has come up. So have you got any particular preference of one over the other?
So even with the ERT2, which is recently published trial in American Diabetic Association, all these 4 SGLT2 have a CV outcome trial data. One thing was common, that all of them had shown a hospitalization for heart failure was significantly reduced. So one thing is very clear, that SGLT2 is a molecule which decreases the hospitalization for heart failure. If you see the sub-analysis for other molecules and the credence, which is a dedicated trial for a renal outcome of a canagliflozin, and now we have a DAPA CKD trial which is going on, and even a EMPA CKD trial which is going on. What we had seen, or even in the EMPA reg or in DAPA heart failure trial, or in the patient with a DAPA CVOT trial, declared TIMI, what we had seen in sub-analysis, even the person's kidney failure, further progression is also halted. So all these SGLT2 definitely they decreases hospitalization for heart failure, and they are helpful in the patient who is having diabetes nephropathy or diabetes renal dysfunction. If their EGFR is more than 45, it should be initiated, and it can be continued till it goes up to 30. But now the data is coming even up to 20 or 15. Also, it can be continued. These two things are common. Now, the absolute death, CV death, which is only seen in a cardiovascular trial, which is EMPA reg outcome, which was not seen in Credence so much, or in Cana trial, Canvas trial, as well as even in DAPA declared TIMI. So that's also very clear. But even these are the two which is major important point. The major MACE were dependent on hospitalization for heart failure. At present, we don't have the data for REMO, but the mechanism of action is same. So probably the heart failure part and CKD benefit should remain with that SGLT2 class. Even this is not been studied for that. The data with the R2 also had shown almost similar, but we don't know the all MACE, all 3-point MACE is going to decrease. With the REMO, we don't have the data. The way we were thinking for R2, it had not shown the data for the favor of 3P MACE reduction. It has shown only benefit for hospitalization for heart failure. So this is very, very clear. But all these SGLT2, there is a slight increase of signal of increasing the stroke, which is not there with GLP-1 cardiovascular outcome trial. So I mean, that's again very important, that GLP-1 is actually anti-atherosclerotic. It decreases overall the angina, the Rewind trial, if you had seen the primary and secondary outcome data of that. So, I mean, these are the molecules which are going to have the effect at the coronary artery disease, while SGLT2 is primarily for heart failure. Heart failure is not macrovascular complication of diabetes. It's a mix of that, or it's a separate complication of a diabetes is a heart failure, which is important, and these are the patients should be on SGLT2. I may choose any of the SGLT2 at this point of time. Definitely, we don't have the REMO for cardiovascular outcome trial, but I'm sure at least it will be also having the benefit for heart failure as well as for kidney failure patients.
Okay, thank you. Now, another common situation which our doctor faces is, somebody who comes for a periodic follow-up, and there are people who will just come once in 3 months if doing well, post-lunch and A1C. So, somebody who comes with a fasting well controlled, post-lunch well controlled, but A1C is surprisingly on higher side. So, that is one scenario.
More drug and this patient sugar is not controlled, probably I don't think this patient will be getting good control by adding only the basal insulin, because patient may go in hypoglycemia. So here if I add the basal dose will be very very minimal, but I have to talk to the patients more about the nutrition counseling. But you have a patient with a 8.5 or 9, fasting sugar is 180, post meal sugar is 250. These are the patient a basal insulin perfectly fine, because if I add, I will try to get from 180 to 110. When everything will come down, I'm sure the post meal glucose level excursion will also come down. So that's the second part of the story, the basal insulin. If I am adding only a basal insulin, I will prefer analog, which is a basal insulin analog. While the if I am putting the patients on a premix insulin, I can choose any of premix analog, because premix analog, the biggest advantage of analog, that can be taken just before the meals, and many of Mumbaikars will not wait for half an hour to take their meal and taking the insulin half an hour before. So for them, it will be good if they are putting them patients on a premix. I think analog mix have a as over the regular premix, because they have to wait for half an hour. I had hardly seen a patient who was taking a regular premix and waiting for half an hour and then taking a meal. I'm sure Ketan bhai, you must have also not seen the patients. Patients are not ready to understand, and even if we explain 100 times, they still take it, and they take it and they just try to eat. So for that benefit, I think these analogs are working very good. So, I mean, any of these molecules which you can start with, but please see the glycemic pattern of the patient, and depending on that, you have to choose which insulin you want to add to the patient.
Right. I would just differ by one statement about the Bombay car. Ahmedabad is no behind, and
I mean,
even Ahmedabadis don't like to wait.
no, no,
So
I
that is
fully agree.
that
I
is a
fully
point.
agree.
And because Ahmedabad is also racing ahead in every way now. So that's a very nicely explained to our delegates. Now, before I end, my always favorite question about, would you recommend role of additional nutrients or nutraceuticals in a diabetes prescription, be it omega-3 or vitamin D or tocotrienol, or what will be your take on that?
So, Ketan bhai, first of all, thank you very much for, and this is the last question. So, first, I must thank you for all the, we have taken almost all aspects of the diabetes. But one thing which is, because it's a primary care physician, and I want to tell that monitoring, I think we are missing in our diabetic patient. And most of our diabetic patients, they don't come to the doctor regular follow-up, because patient is not talk so much about the monitoring. So I will request all my participants and all my friends who are participating in this particular webinar, that we should ask our patient to monitor regularly. If they will monitor regularly, if they will find their sugar is uncontrolled, I am sure they will contact you either on phone, on teleconsultation, or face-to-face consultation. So this will not only give you an opportunity to meet the patient and to escalate the therapy as and when required. The last part of your talk, which is nutraceuticals, that nutraceuticals, vitamin D and B12 have definite role in our diabetic management. If you have a low vitamin D, definitely you would like to add that patient. Vitamin B12 deficiency commonly seen are vegetarian, are Gujarati patients, and many more who are pure vegetarian and who are taking metformin. So that's also very common. Now this year, last 2 years, ADA is recommending that B12 should be checked in all the patients who are taking long-term metformin therapy. So I do give my patients vitamin B12 and D. Regarding vitamin E, which you are talking, or coenzyme Q, or other nutraceuticals, it is at present, or any other antioxidant, there is no data, there is no scientific study which had come up in such a way which had shown the benefit in in a number of patients, to show that it had never come in the guidelines. So at present, from RSSDI to ADA to IDF to American Association of Clinical Endocrinology, we are not recommending any of these antioxidants or these nutraceutical to all our routinely patients. But as an individual, we may decide for X, Y, Z patient, but not from A to Z all the patient. That's very, very important. And I think take off message. I do give coenzyme Q. I do give some patient tocopherol. Like I would like to give patient with a fatty liver, patient because that's a vitamin E, patients with lot of calf pain, we may give coenzyme Q or vitamin E. So I mean, it depends on condition to condition, but not to all my patient, not A to Z. It's not a blanket therapy for all our patients.
Right. So it will be on an individualized therapy depending on the patient's additional components which can be offered over there. Very nicely said that. Dear friends, we have really seen how the basic certain concepts which has been made very clear by Dr. Bansi Sabu. In fact, we have been, when we have to discuss about diabetes and management, we have almost like a 3-day conference, but we could concise whatever the salient points, take home message which he has given. The very crucial point is hit early, hit hard, which is the message given by Dr. Bansi Sabu. We need to be really aggressive if we want to have a better outcome, if we want to have a legacy effect of diabetes control in the long run. And we have seen, I'm sure Dr. Bansi Bhai and all, we have seen that there are people who are diagnosed diabetes and have over 30 years, 40 years have also pulled also without problem also. So it is all how we involve the patient and the family in management of diabetes. So thanks to all of you for actively participation. My special thanks to Dr. Bansi Sabu on, in spite of his such a busy schedule, he could spare some time to give us a time. He is at present actively involved in RSSDI. And before we come to the vote of thanks, I would invite Harish Mehta from InnoCare to say some few words. Harish.
Yeah,
Thank you,
Dr.
Ketan bhai.
Ketan Mehta, and good evening, Dr. Bansi Sahu, and good evening, all the lovely participants. Myself, Harish Mehta, working as a marketing manager, and this entire webinar is organized by the InnoCare Life Sciences Company with the help of IMA Mumbai. And just wanted to give you a brief idea about the company. InnoCare Life Sciences is almost like 5 years old Mumbai-based company, and it is operating across all India. InnoCare Life Sciences is always known for innovation and innovative product. And the InnoCare is majority of the places is known for 3 major brands which we are promoting to all the cardiologists, diabetologists, that is T3, T3D3 and T3LC. So just wanted to give you about the basic information about the tocotrienols. The tocotrienols is a 40 times more powerful antioxidant property as compared to vitamin E. And there are a lot of studies are available which says that tocotrienols has capability to reduce a total cholesterol level by 15%. These are the human clinical trials. Apart from this, tocotrienol also has potential to reduce LDL cholesterol by 8% and also reduces triglyceride approximately 28%. Apart from this tocotrienols, in our all 3 SKUs, these tocotrienols also work in a diabetes condition as well by regulating PPR genes, improves the glucose utilization, and also improves the insulin sensitivity. Apart from this, we have in a diabetic complications, we are offering methylcobalamin along with the L-methylfolate, pyridoxine 5-phosphate, so which basically take care of neuropathy, retinopathy, and nephropathy cases. And from the entire InnoCare Life Sciences company, would like to say thank you so much, Dr. Bansi Sabu and Dr. Ketan Mehta, for giving a valuable information and insights related to diabetes and diabetic complications. Thank you so much, sir. Over to you, sir.
Thank you.
Yeah, we'll invite Dr. Rashmikant Sangvi if he's there.
No, he's not there, sir. He's not there, sir. We
There
can close up.
of blood level of
Ketan
Okay,
bhai,
so anybody, Dr. Akhil Contractor or Dr. Shobha Ahuja, they are not there. So on behalf of Indian Medical Association, Mumbai West, I thank all of you for participating with us. Thanks to
not going
obviously
through.
Dr. Bansi Sabu and InnoCare for participation, giving unrestricted educational grant. We are going to
Sound is not
continue
coming through.
of experts talk, and next week, that is on 8th of August, we have another special session on unanswered questions in rheumatology for family physician. and we have with
Hello.
us Professor
Sir,
Dr.
can you hear me?
Yeah, Dr. Sangvi.
Hello.
Yes, go ahead.
Hello.
Yeah, go
Dr.
ahead.
Ketan.
Yes, go ahead.
I have question. I have sent the question regarding the minimum level of the empagliflozin required to give the heart protective effect.
Yes. So, Dr. Bansi has left, but I would say even the 5 milligram is good enough to start having a cardioprotective effect. So 5 milligram itself good. So any dose, higher the dose, obviously the cardioprotective effect is better. But even at a lower dose, the effective cardioprotective effect starts. So thanks to all of you, and we will meet again for unanswered questions in rheumatology
Thank you.
next week.
Thank you all the participants. I thank Dr. Sabu also for his participation and his all the guidance that he has given. We are very happy to be joined with you. And our special thank to Dr. Ketan Mehta to invite Dr. Sabu. And sir, we look forward to further second session from Dr. Sabu also. Thank you.
Okay.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you.
Yeah.